Thank you very much, Dr. Bader. We should now move to the next case. Our next case is a complex case presented by Dr. Nouf Alanazi from Saudi Arabia.
Oh, by the way, Dr. Nouf, she apologizes for not coming. There is a miscommunication about the timing. We thought it's going to be 6 p.m. Saudi time, and so she's sorry about she cannot make it. So I just want to.
If the organizer will want to present her case, or we move to Dr. Samih Lawand, for the organizer for the cases, if we can move to the third case.
Hello, everyone. Thanks for having me tonight in this very organized, high caliber meeting. I'm going to be presenting this patient who's a 70-year-old male with known history of diabetes on oral hypoglycemic agent and HbA1c of 6.7, fairly controlled, hypertension, coronary artery disease, previous CABG in 1998, LIMA2 LAD, SPG2-OM, and SPG2-RCA, mild aortic stenosis and peptic ulcer disease, previous GI bleed more than 15 years ago. Not all details were available, unfortunately, but he mentioned that he had no blood transfusions, and he has an older report that says his scope showed clean-based duodenal ulcer. He presented to the clinic initially in 2014 with exertional angina, underwent an angiogram that showed significant disease involving his left system, ostial left main, mid-segment of the LAD, calcified vessels, occluded RCA with collaterals to the PL and PDA. For the sake of time, I'm going to go a little bit fast on the angiogram, but as you can see, there's significant proximal and mid-segment LAD disease, left main disease. His lima is atretic and occluded. His RCA is 100% occluded. His grafts, both to OM and to the RCA, are unfortunately occluded. Revascularization options were discussed at that stage. Patient refused any kind of intervention and opted for medical therapy. It was optimized. His symptoms resolved. He continued to follow in the clinic until 2019, when he presented to the emergency with progressive exertional angina for 3 months. Got worse over the last week prior to his presentation with CCS class 3 angina. His pain was improving with rest and sublingual nitrates. He denied any other cardiac sounding symptoms. On examination, he was hemodynamically stable. Heart rate was fairly controlled. He was not in heart failure. He had an ejection systolic murmur consistent with his aortic stenosis. Nothing remarkable on exam. His initial sets of troponin were 74 and 81. He had a baseline microcytic hypochromic anemia at 11, stable for many years. Nothing else that sticks out in his investigations. His ECG was fairly similar to his baseline, no acute dynamic changes. He was admitted and treated as ACS with dual antiplatelet therapy and anticoagulation in addition to his home medications, and angiogram was done. As you can see, he has significant disease that is definitely worse than his previous angiogram, including his ostial left main, proximal LAD that is heavily calcified, and the mid-segment of his LAD. We can still see some collaterals to the PDA and PL. Diffuse disease, small caliber vessels in general, but the significant lesions are fairly worse this time compared to the previous angiogram. There was significant dampening every time we engage the left system. This is his RCA that is similar to previous. We limited the number of views due to significant dampening. It was clear that the issues that we're facing here are how bad is his aortic stenosis, given that his last echo was about 2 years ago, and how to approach his anemia. His mean gradient during the angiogram was around, his gradient across the valve during the angiogram was sitting around 18, and echo was obtained, shows normal LV function. His aortic valve was calcified, but still opening. As you can see here, discussed with multiple echocardiographers. Eventually, the consensus was that his aortic valve was in the moderate range with a mean gradient of 20. So the risks against benefits were discussed extensively with the patient and his family. We looked at the risk of bleeding, looked at the risk of having any future ischemic events. They were comparable. A patient did not report anything suggestive of GI bleed over the last at least 5 to 7 years. He did not notice anything. So we elected to proceed with the PCI. Obviously, he doesn't have any reserve, so we decided to go with Impella for mechanical support. It's calcified. Rotablation was planned. IVUS as well. Stent options were discussed to consider anything that would enable us to stop DAPT prematurely if needed in the event of bleeding, and the option of DAPT duration. The options of duration were also discussed prior to proceeding. Access was obtained. We checked both for Impella and for the procedure access. Impella was implanted with no issues. And then I have elected to pre-dilate and see if the lesions will yield easily, and they actually yielded easily. There was a lot of recoil, but eventually I managed to deploy the stents in the mid-segmental proximal and in the left main, post-dilated up to 3.5 in the left main. Very reasonable results eventually with no complications. And during the procedure, patient was fairly stable, and there was no issues. However, a few hours post, he became drowsy, blood pressure dropped to 80/40. He was oozing from the access site, and his hemoglobin dropped from 11 to 8. Resuscitation measures were all done, including compression, blood transfusion, IV fluid, inotropes. CT scan was obtained, and there was no retroperitoneal bleed. Eventually, bleeding was controlled conservatively, and patient was stable. We observed him for a few days post, and he was okay. We continued on DAPT, Plavix, and aspirin for less risk of bleeding, pantoprazole indefinitely, and with clear instructions to come to the emergency in the event of any bleeding, follow up in the clinic after 1 month and 3 months with hemoglobin levels. He was seen, he was asymptomatic, hemodynamically stable, and hemoglobin was stable around his baseline on discharge. However, 6 months later, I was called by his son, who was concerned about the new symptoms. Post-angioplasty, he remained active, was able to go back to his usual activities. However, around a month to 2 months before his phone call, started experiencing exertional angina, progressively worse over the last 2 weeks prior to presentation, CCS class 2 to 3. He denied chest pain at rest and other cardiac sounding symptoms. Limited activities was very clear. He believed that symptoms he was experiencing was similar to the pre-procedure symptoms. He was compliant on medications. He denied heartburn, melena, hematemesis. He was hemodynamically stable, and physical exam was unremarkable compared to the previous presentation. So the possible causes are either GI bleed or obscure GI bleed or in-stent restenosis. However, it's a fairly short duration, and we were happy with the results of the procedure and the IVUS result that we couldn't show today. Patient was admitted, investigated. Everything was within the normal range except his hemoglobin level that was 6.7, microcytic hypochromic anemia, no clear source clinically. He was started on IV PPI, iron studies obtained. Other studies like hemolytic anemia studies were obtained. Everything was within the normal range. Transfusion was done, 2 units of packed RBCs, and GI consultation was done. Scopes showed no clear source of bleeding. Everything was normal, and we could not identify the source of bleeding. It was assumed to be somewhere in the small gut. Capsule endoscopy was discussed with the GI. However, they did not want to proceed with it unless he declares himself again. So I elected to stop his aspirin and continue with single antiplatelet strategy and iron supplement and follow him in the clinic. I've seen him a few times since, and thankfully he is stable on single agent antiplatelet and with no obvious bleeding so far. That's my case. Thank you very much.
Well, thank you very much, Dr. Nouf Alanazi from Saudi Arabia. Unfortunately, physically, she's not with us, but we would like to thank her for presenting her case. Dr. Ahmed Majdi, I would like to give you the talk or the chance to comment on the case, but I think the message here in the last remaining vessel in high-risk complex patient, would you agree with the role of Impella and the other things? If patient have a high risk of bleeding, what is your shortest, despite the PCI in this remaining, including left main, the shortest duration of dual antiplatelet and the selection of P2Y2 antagonist?
Thank you, Professor Musa Akbar. Well, learning points from this case are multiple. If we start by Impella, yes, Impella in patients, sometimes you use it the patients who are hemodynamically compromised to improve the cardiac outputs. We are doing webinars with the American and the European colleagues of us, and يمكن last week كان معنا Professor Amir Kaki from Detroit Medical Center, who he presented in the ischemia club the first case where they used Impella, special Impella, to give 4 liters of blood. فالبيشنت كان cardiac output 1.2 or 1.5 بقت 4.5، وبالتالي حصل وبقت كمان smaller in size. في حالات تانية they are not in shock but they are liable to have complications during the procedure because of this critical left main and critical LED. وبالتالي Impella is replacing the intra-aortic balloon. In the past, they are using, and now there is a new concept called the protected PCI, where in such very high risk patient, there is a score for this and there is an algorithm. I'm sure everybody know about that. And one of the cornerstones هو الإمبيلا، أو إذا كان أحيانا بعض الحالات دي تستخدمه حتى الإكمو أو other device. النقطة الثانية إن هو according to myocardial revascularization guidelines European Society, when you have a patient with a previous CABG and then this patient is presented with angina or whatever, the main objective is to improve the native arteries, except if there is some cases where there is distal left lima or something else. However, you work on the native vessels. That's what they did because yeah, there is another option. If you are too enthusiastic, you try to improve the bypass grafts, but here they did well. The last question regarding this atypical patient is old, is having multiple risk factors. That score was high, and so he had the local bleeding. This patient with left main and LAD, and maybe this is the only artery that is functioning well. Maybe I can give him longer, as long as possible, because of the high risk, according to the guidelines, also the ADAPT guidelines of the European Society. However, we should take precautions. Maybe this is not a patient for Brilic, not a patient for ticagrelor. We can use Plavix and aspirin. And now the new concept of SAPT, that you can use only one antiplatelet after a time. And this is now replacing the aspirin that you are using Plavix or 60 milligrams of Tica twice daily. He's like, and he had this bleeding twice, once in the procedure, and then he came back because of the antiplatelets after a long time. So you be cautious, but of course you need to keep him on Plavix for life because maybe this is a left main and other. I will give the time. I don't like to take more time, so my colleagues can also comment.